what kind of psychosocial support I try to provide and offer to my patients, it depends on what their needs are. Some of them come in with really extensive families and a big network of support, and they don't maybe need something immediately. The patients that don't have as broad of a system of support, I think it's really about interrogating that in the first visit or two and figuring out who their people are, what is their system, how reliable is transportation for them? Are they able to drive themselves, or are they dependent on someone else? Who's that person? The other piece I think is, symptom management. What symptoms are they having from their cancer that need to be addressed? We frequently utilize our supportive care team or palliative care team. I'd say they see 9 out of 10 of our, metastatic lung cancer patients, because they're able to provide, not just symptom management, but they really help with the goals of care conversations, being that added layer of support, maybe being able to spend even extra, time with the patient. So I'm very quick to refer to our palliative team. If I, meet a patient who is really struggling to cope with just the diagnosis of lung cancer and the prognosis, and they're, having trouble sleeping, or they're getting agitated or anxious, then we'll bring in our psychology team. We've got some wonderful psychologists that work with us, and we'll, try to get them appointments with them, just to have someone to verbally process with, maybe try some, cognitive behavioral therapy strategies. And then personally, if I get a sense that, the caregiver or the patient, they just need that extra layer of support, that extra availability. I know that our phone systems can be trying sometimes. People will call and, you have to press all the numbers and then leave a message, and you're supposed to get a call back. And we work really hard to do that. But sometimes, I'll end up giving people my email or my cell phone if I feel like they just need that extra security that they can get me if they need me. And most of the time, patients and loved ones respect that and don't call at 10 p.m. most times. But I think making yourself available, the physician I work with, she puts her cell phone on her business card, and we really just try to, make sure the patient knows if something happens, here's the numbers to call. We're here for you. We've got a big team, available to help you. Sometimes it's nutrition, dietitian referrals to help with anorexia and things like that. So I've kind of got my system of ancillary, staff that I refer people to, and then I try to do as much on my own that I can, just to build that rapport with the patient and their family.
I do most of the counseling myself for Psychosocial. One of my favorite booklets that I like to give out at the very beginning of treatment is called Taking Time from National Cancer Institute. I love to remind the patient that, whenever you get a diagnosis of cancer, you can go on a little bit of an emotional roller coaster. And that's the same thing for the patient or the caregiver. And I just want to validate that all of the feelings that they may experience, those are real. Whether it's denial, whether it's anger, fear, or the place of acceptance or hope. I really like to emphasize for them to keep communications open between the two of them, and to be honest about how they're feeling about their diagnosis and their treatment. And I also like to remind them that they may have some very well-meaning friends that want to give them the horror story of their uncle's third cousin, twice removed, experience with lung cancer. And just to remind them that they need to set boundaries, and share that I would rather them not hear that story. I would rather for you to listen to what your medical oncologist and your team are telling you from the hospital. And that seems to be quite helpful for most of the patients.
I have had the great fortune of working with some wonderful oncology social workers. And I've also had jobs where I have not had any psychosocial support. So like Lauren had said, she has a very strong palliative team and the psycho-oncology team. And when I worked in an academic setting, we did have those, and it was wonderful. I also had 3 years where I was in a community setting, and I worked with an oncology social worker, and we worked hand in hand. She even did, counseling. But my previous position from here, I was everything. I was the dietitian, I was the financial counselor, and I was the social worker. Certainly if they were in a great deal of distress, then we would refer them to our psychiatric team. But yeah, no, I definitely think as an oncology nurse navigator, I have been so blessed and so fortunate that I have the time to sit with patients and their families and really get to know them. I think the more they trust you, the more they get to know you, the more they open up to you. So I've been very fortunate in my practice over the last 8-9 years that I am able to form the relationships, kind of get a sense of what they need, and really stress to them that I am here for you, I'm here for the patient, and I'm here for the family. And that, our phone, and also fortunate that, someone always answers our phone, so they feel that they can always get a hold of us. So I guess I'm spoiled, let's put it that way. But yeah, psychosocial aspect of my practice is, a great deal of it. I think that one of the things that are most important about their psychological status is to let them know that it's okay to be fatigued. It's okay to be tired. Some of them want to continue to do all the things that they were doing, and just to listen to what they're saying and give them permission to, take a nap. I also stress to them fatigue is a normal thing when you're going through therapy, but if you can take a walk around the block and not lying in the bed all day long, things like that, they know that my experience, they learn to trust what I'm saying to them and be able to take that home with them. Also, you see a lot of caregivers that are stressed, and if I could just sit down and do an assessment, what is stressing them out most? Like I alluded to earlier, the fact that the patient doesn't eat is a big stressor for caregivers. Also, I'm always amazed at how patients, at least in my practice, they don't really come out and ask, how much is this all going to cost? And so I reassure them when bills start coming in, bring them in, we'll go through them, because that is a major stressor for the caregiver, sometimes the patient, but it's usually the husband or the wife that's trying to manage all these and protect their loved one. So just knowing what their stressors are, and then being able to address them is to my best ability. If it's a matter of applying for a copay foundation, because that'll help their 20% copay. Things like that really are important to patients, and just, addressing their distress is, can just really help them out.